And if we go back to like my case, so I take it. I've been taking it since I was 14.
Why at 400 some guys feel completely fine and some guys can't get out of bed in the morning?
What's the point, eh? Lovely head of hair, no sex drive. There's no point, is there?
What's the best type of exercise for improving testosterone levels?
Maybe you need to take some Tonka Ali. Been trying for a baby, been absolutely smashing it. Feel really good.
Testosterone is most often talked about in terms of sexual function. So women that report loss of libido, loss of pleasure from sex, sometimes testosterone is piggybacked onto HRT.
Welcome to episode 6 of the Best of Both Worlds podcast and part 2 in our series on testosterone. This is the ultimate in healthcare conversations where we look to discuss, consider and potentially find the humour in our quest as healthcare practitioners to optimise performance. That is sports performance, psychological performance, emotional performance, and just performance in life in general. We hope to learn with you, to share with you, and create powerful, high-performance lives. I'm Matt Winter, Doctor of Physical Therapy with training in functional medicine, and I'm here with Paul Macaulay, Senior Podiatrist, otherwise known on TikTok as the legendary Paul the Podiatrist. Welcome back, Dr. Neil Forrest. Let's begin our conversation of part 2 on testosterone.
Let's talk about testosterone therapy, something I know a lot about, as I've been taking it since I was 14 years old. So what are your opinions in general? Is it something that you support? And what are your indications for it?
Okay, so the support part's easy. Of course I do, absolutely. I mean, you're sitting here right now talking about the fact that you're using it, you're getting benefit from it, and I prescribe it for patients. And so, yeah, I think that's the easy part. How and when you use it is the big question. So there are some cases that are super clear cut, right? So I don't know if you're going to talk more about your experience, but someone that has an endocrine or a genetic condition that gives them a true testosterone deficiency, it's kind of a no-brainer, right? You know, you're not going to want to try and restore to physiological levels. I think when it becomes a more nuanced conversation is more in this spectrum of age-related decline, in people who don't have identifiable endocrine reason for it, and so then it's a question of who gets it, under what conditions, and how. And so I think it has to be very, very individualized for a number of reasons, partly because the absolute number doesn't always tell you the whole story, and partly because the causes of that person's low number are so multifactorial. So I think the nice way to think about this is if you think about the stages of testosterone production or triggering in the body. So you've got the hypothalamus in the brain, which secretes a hormone called GnRH, gonadotropin releasing hormone. That tells the pituitary gland to release LH and FSH, luteinizing and follicle stimulating hormone, which are present in men and women. And then it's those hormones that then have a bearing on the cells in the testes in men to produce testosterone. So there's various stages of that can be impaired, and the whole thing's a negative feedback loop. So testosterone levels are high, that's sensed, and the hypothalamus and the pituitary stop triggering the testes to produce testosterone. Does that make sense so far? Yeah. So is the problem that your testes just aren't capable of producing as much testosterone as we need or want to have? Or is their production being switched off at higher levels by the pituitary gland? And so I think the nice way to think about this is to sort of use patient examples or use human examples. So you see a guy that is obese, he smokes, drinks every night, doesn't do any form of exercise, has a super stressful job, his sleep's terrible, his diet's full of processed food, and you check his testosterone levels only. You might see a lowish testosterone level and think, well, there's your problem. I'll give you some testosterone. But actually, if you checked his FSH and LH levels, they should be high. You know, if his testosterone level is low, the pituitary gland, the brain, should be saying, where's the testosterone? Come on, let's produce some more. And they're churning out FSH and LH to try and stimulate the testes. So if that hasn't happened, let's say we check his levels, and what I'd expect to see in this guy is low LH and low FSH, that's because his lifestyle is impairing those things. So he's metabolically unhealthy, his circadian rhythm's off because his sleep is out, his cortisol's sky high, and so he's not triggering production. And he might see more benefit from adjusting his lifestyle and addressing those other issues, and then we find his testes are naturally capable of producing all the testosterone he needs.
So it's so good to outline the physiology of that. I think, instinctively we might know that this guy clearly needs to sort out his lifestyle factors. He's overweight, he's not sleeping. And we'll come back to, I really want to ask you about lifestyle or pillars of lifestyle medicine that we can use to increase testosterone naturally. But I didn't realize particularly that it was to do with the health of the pituitary gland. And is that what you're suggesting there? So these factors, they directly affect the pituitary gland health, and therefore the output that leads to the testosterone.
It's the health of the pituitary gland,
the
the way the pituitary gland behaves. Yeah, absolutely. And this is probably where cortisol is playing a role, where inflammatory markers are playing a role. So if you look at the UK guidelines, where I think all three of us are originally from, in terms of who do they tell us to check testosterone levels in? One of those is anyone with obesity, or any man with obesity, and one is anyone with diabetes. So metabolic health is a huge part of this process. And again, some of this is probably the body doing what it's supposed to do. It's prioritizing certain things. I've got a lot of inflammation. I've got a lot of stress. I'm not sleeping. I don't need testosterone right now. So some of it has very sound physiological basis.
It's adaptive rather than maladaptive,
right? Exactly. The problem with stress is it's supposed to be finite. It's supposed to be short-lived in evolutionary terms. I mean, so you're a gazelle grazing on the savannah. A lion jumps out the bushes, chases you around for 10 minutes. It either catches you and kills you, or you escape and the stress is gone, and you sort of go back to doing what you were doing and plodding along. And that's fine. That's a fight or flight response, and the body is well tuned into that and very optimized to handle that. It's why we have cortisol and adrenaline and the ability to run away from danger. When the stress becomes chronic, you're doing a job that you hate, or that is unmanageable, or you're going through financial difficulties or relationship difficulties, and the stress is there every single day. That's what leads to poor health outcomes. It's not getting super anxious or stressed about something for 15 minutes, dealing with the problem and then moving on. That's good stress management. So when we talk about stress, it seems to be the chronic stress that's a problem.
Do we need to be testing that? So, or is it just we get enough information from that patient, the interaction with the patient, or is there a role for testing cortisol, LH, or FSH? Do you ever do that?
Yeah, so there is a role for it, although I place far more importance in what the person was telling me than any levels. One of the problems with cortisol is we're checking a snapshot level. When I check your cortisol level, I'm seeing what your serum cortisol level is at the moment we drew the blood from you. That has natural circadian variation anyway, so we try and check it in the morning. But even then, reference ranges are huge. People respond to different levels. Probably a more accurate way of doing it is a 24-hour urinary cortisol collection, which means collecting your urine for 24 hours. Not the most convenient thing to do, and so it's probably not necessary in most people. LH and FSH definitely has an importance when I'm thinking about testosterone, both from trying to work out what the underlying cause is, and also whether and how to treat or not medically. That can be a deciding factor.
I guess there are other medical causes there, right, that can interrupt.
If we circle back to when I asked you about testosterone replacement therapy, and you said that you're in support of it. And if we go back to my case, I take it. I've been taking it since I was 14. I take it every 10 weeks. In the NHS in the UK, they were like, "You're gonna stick it 10 weeks and that's it. No more."
Yeah.
Probably because of budgets. But I came here to Singapore, and the doctor's like, "You can have as much of it as you want, whenever you want." And then I'm like, "What?" In that case, I'm like, "Oh, what do I do?" And so I just stuck at 10 weeks because I was a bit worried. And what do you think is the case?
So it's a good question. And this varies between countries, both in terms of what people get advised, but also the forms of testosterone, the formulations that are available. So I think what you're talking about is Nebido.
Yeah,
right?
that's
so
correct.
Nebido is the brand name of an injection of testosterone undecanoate, so it's a form of testosterone that we can give. It's one of the two forms of testosterone treatment that's commonly available in Singapore, the other one being a gel. It seems, I mean, I listen to a lot of podcasts around this topic based in the US. Doesn't seem to be a thing there at all. So in America, you have testosterone gels, but you also have bead implants. You have out and out testosterone injections. So guys drawing up with a needle and syringe and injecting themselves every day, every other day, twice a week. You know, pick your regimen. That's not so much of a thing here, and I know it's not so much of a thing in the UK as well. And I'm talking in the medical context here, not in the illegal sort of performance-enhancing procurement where I'm sure injections that you do yourself are available. So Nebido is an injection that would be administered normally by a medical professional. You wouldn't do it to yourself. Actually, the guidelines for Nebido are 12 weeks. So the standard recommendation is that you have an injection every 12 weeks and that maintains your testosterone level. But it is uneven. Yeah. So as you mentioned, it would be higher at the beginning and then people feel it tailing off. And responses vary. So I wouldn't necessarily stick to 12 weeks. Yeah. I would want to know what your levels are doing and how you feel at those levels. Strictly speaking, there's no medical reason that you can't have it more frequently than that. And I do have guys who have it much less frequently than that. They actually find that having an injection every 6 months seems to be good enough for what they want. So that's in Singapore, and I guess we're here, we should talk in a Singapore context. We've got this Nebido injection and we've got testosterone gel. The annoying thing about the gel is it comes in sachets, so you can't even get the pump, which an androgel pump is very widely available in Europe. Yeah. I don't know why we can't get them here, but right now we can't because it's just a more convenient way to dispense. Yeah. When I start someone out, I tend to prefer to start them on topical testosterone because it's really easy to back out of if you don't like it. You know what I mean? You can stop whenever you want. The problem with an injection that lasts 10 weeks or 12 weeks or whatever is once I've done it to you,
it's in.
That's it. Yeah. So if you decide after 2 weeks you hate it, you feel terrible, which is unlikely, of course. I hope that I've given you the injection for the right reasons. But if you do, we're stuck with that decision. Yeah. So what I would generally do is start someone off on topical, get them to a level they're happy with, and then if they wanted to continue and they wanted the convenience of an injection, migrate them over to that over time. That's how I'd approach it.
I think as we become more informed as a population group, there seems to be a little bit more push for things like health screenings. And of course, I think that's a very much a double-edged sword. We see that a lot here. Is there a role for screening testosterone levels? If so, when would you think about starting that? And then is there a level that we're looking at that's normal or that defines abnormal?
Okay. So I don't tend to randomly screen people. So I would test more based on reported symptoms than just wanting to know your level. So there are some things where I want to know your level without you experiencing anything from it. So I might want to know your cholesterol level or your blood pressure level, and you can't tell me what that is in any way based on how you feel. Just have to know the number. I don't think testosterone's like that because you see people with very different levels feeling very different symptoms. So actually knowing the number at random isn't that useful. I'd never deny anyone who wanted to check it. So if I'm seeing someone who's in for a screening anyway and we're checking their general blood work, they want to do a testosterone level, no problem at all. But I'm not going to go out sort of saying randomly, get it checked for no reason. Clearly for men, it tends to be with age where it starts to be more on their mind. So it would be far more common for a guy in his 50s to ask me to check his testosterone than in the 20s. But in anyone who is experiencing symptoms at any age, it might be something to think about. So then is the question of well, when and how do you check it? We'll come on to natural ways to boost testosterone later, but the reason sleep is so important is that testosterone isn't constantly secreted through the day. So these higher hormones that we talked about with the pituitary and the hypothalamus are pulsatile in nature, and testosterone levels tend to peak in the early morning. So we need a good night's sleep to have a healthy level of testosterone. And so we normally aim to check it somewhere between 8 and 9 a.m. in the morning. And that's where your sort of reference ranges will be set. So you want to be able to do intra-patient comparisons. If I check you in March, I want to check it again in April. I need to check it at the same time of day. But that's where everything is standardized to. So you need to do it in the morning. So sometimes a guy will come to see me. I won't know why he's coming in. We'll have the conversation at 4 o'clock in the afternoon, and I'll say, look, sorry, we can't do the blood test now. You're going to have to come back tomorrow or at the weekend, and we'll do it in the morning. So that's the timing part of it. It's just a blood test. So the test itself is pretty easy. At Oslo, we think pretty carefully about where we send our blood tests. So there's 2 big labs in Singapore that process most of the blood tests here. For testosterone, I actually send mine to a different lab because, just from experience of being here a while, for this particular test, that's the lab I've found consistent, trustworthy results and reference ranges from. And generally when we check it on the testosterone front, not talking about FSH and LH and all these other things that we might want to test, but purely from a testosterone perspective, we test free and total testosterone levels. So I guess we should explain what those are.
Yeah, so free testosterone we've got floating around, and then testosterone that's not free is attached to sex binding
SHBG, sex hormone binding globulin,
which is this like shuttler, right, which sends it around the body, right?
And albumin. So most of our testosterone, most of us 90-something% is bound to either albumin or SHBG. And it's only the free testosterone that exerts any of the effect of testosterone. So you have this massive amount, and most of it is inactive at any given time. Of course, it can be unbound and can go on to exert its effect.
Is there any supplement you can take to get less stuff to split off the binders?
Some of the supplements that are purported to increase testosterone levels, if you trust the data, have been shown to boost free testosterone preferentially. Those other things that we mentioned, albumin and SHBG, we can check those levels as well, so we can see. I mean, that's how the lab are calculating in part of the free testosterone calculation. The other thing that not in the lab that I use, but you see sometimes quoted, if you're reading around this topic, you might see is the free androgen index, which is another way of trying to express this idea of how much bioavailable testosterone you might have. They're all slightly different ways of trying to say the same thing, but it's the free testosterone we're most interested in. So someone might have a very high, healthy level of total testosterone, but if their free testosterone's on the floor, they could still be experiencing symptoms.
From what I understand, the bound testosterone is still useful. It's just making its way around the body, being bound.
Yes.
It's being taken somewhere potentially. Why would someone then have a very high bound testosterone, but it's not being able to become free testosterone?
Yes.
Is there an issue there in a pathway somewhere?
So sometimes it can be related to their metabolic health. So again, when we come back to lifestyle on this, there may be some conditions, particularly things that affect the liver, that might affect your albumin levels. So we do see people with alcohol issues have lower testosterone levels, people with fatty liver, but that's bound into metabolism and pre-diabetes and that sort of thing.
So that's elevated albumin, is that
yes,
right? So then
correct.
causing that testosterone to bind
exactly.
and
So
not be
more,
available. Got it.
Yeah, that's the theory. But again, I mean, I think the other thing that we definitely see in day-to-day clinical practice is we know what the numbers are, and we've got a sort of reference range. But the quoted lab reference range, I think ours quotes from 250, this is for total testosterone, 250 to 950. So the first thing you can say is that's a huge range, right? If I check your potassium level, it's 3.5 to 5.2, and you go too far out of that and your heart will stop beating and you die.
Exactly.
So we have these massive reference ranges with some hormones, and that's problematic when you're trying to interpret it for someone. Reference range shifts a little bit over time. So if I see a young guy who's very fit and healthy, works out a lot, and he's got levels of 1100 I'm not going to get too anxious about that. I might check one or two other markers, but that's probably just normal for him. The reference range sort of shifts around. The lab quote a very standard reference range. But why is it that we see, let's take within the reference range at a level of 400, so lower part of the range, but not terrible. Why at 400 do some guys feel completely fine, no problem at all, no reported symptoms, and some guys can't get out of bed in the morning? They're just nothing. I don't know if you can relate to this from
yeah.
from
Well,
Noah
if I don't have my injection like on time, like I've got bad brain fog, can't get my words out, can't.
But do you know what your levels go to within that
I'll have to
that
check
range?
my lab
Yeah.
results.
Because that might be
be
that might be
interesting.
very different to someone else, you know,
Yeah.
at the same levels. So what is it that that we can't measure that isn't giving us the whole story?
And as you said, that all of those symptoms can be multifactorial anyway.
They can, yeah.
So, you know.
But I think even when we're just talking about testosterone, so one thing that we can't measure very easily is DHT. So one of the end products of testosterone that we haven't talked about, as well as estrogen, is dihydrotestosterone, DHT. Now that is about 5 times more potent in its stimulation of the androgen receptor than testosterone is. So it's like testosterone plus. Much harder to measure outside of a research lab context. It's hard for me to just get DHT levels. So it may be, your response might differ because you don't convert enough. Yeah. So there's a hormone called is it 5-alpha reductase?
That's the inhibitors for hair loss.
Exactly.
Yeah.
Exactly. And so there may be that. The other thing that we can't measure is how many androgen receptors you have typically.
Mine are all on my head, sadly.
Yeah. so that varies, and again on a research basis, with all the sort of in university labs you can count androgen receptors, but I can't do that for my patients. So it may be that all your androgen receptors are well saturated, and I could give you as much testosterone as you wanted, and it's not going to have any impact. So I think that's part of the reason why we see guys experiencing different symptoms at different levels, and also why we see a variable response to treatment. Some people, notice a huge impact from boosting their testosterone levels by not that an impressive amount on a blood test. Some take very high doses and don't notice any impact.
So I'm just going to try and summarize this for people listening. So we've got testosterone, and then we have the free test. We can separate that into free testosterone and bound testosterone.
Yes.
Generally, what's active is our free testosterone. It can be overly bound, potentially because of levels of albumin in the blood, which then kind of renders that somewhat inactive, so that you can have high total testosterone but still be suffering from symptoms of lower testosterone because of that. That's one reason. Then second, you've got dihydrotestosterone, which is what some of that testosterone will be converted to, which is, as you said, testosterone on steroids, essentially. And for some people, because of a conversion issue, they might not get that DHT, and therefore they might present earlier with signs of testosterone deficiency or not respond so much to therapy. Yeah. So we've got that kind of spectrum.
And as you alluded to with the hair loss thing, so there are medications that block that conversion to DHT, finasteride being the most commonly used. Now at its full dose, finasteride is used to treat prostate enlargement. And so by blocking that conversion to DHT, you can treat the symptoms of an enlarged prostate, and at 5 milligrams, that's what it does. There is another sort of branded version of finasteride called Propecia, which is a commonly prescribed medicine for hair loss, both to try and restore hair loss or prevent it from happening at 1 milligram, so about a fifth of the dose of the prostate dose, and that blocks that conversion. And so some of the side effects of finasteride are similar to testosterone deficiency, and there is this concept of post-finasteride syndrome, which you see in some men even after they've stopped taking finasteride, where the symptoms grumble on even though the medication's been withdrawn. So that is something to be cautious about. It's definitely a conversation I have in people who want it for hair loss, and prostate is a slightly different conversation. But yeah, for the hair loss thing, this is it's a very
No, but what's the point, eh? Lovely head of hair, no sex drive. There's no point, is there?
well. That's the view that I would take. You have to accept the fact. I pick up a lot of guys when they've already been taking Propecia for a long time, and they say they feel fine. So it's then very hard to argue with, right? They don't have any of the symptoms. But I think, one of the great challenges with Propecia is not never being able to prove the counterfactual. Yeah. How much hair would you have
If you didn't
if you
take
hadn't?
it. Yeah.
It's hard to know for sure, right? Now you can do follicle counts, and certainly you do see guys who've experienced some hair loss. They start on it and they see regrowth, and that's hard to argue with. So it is proven in that regard. But I do sort of think, I see guys with very full heads of hair who've been taking it for a long time, and I sort of say, what? And they'll say, oh, well, my dad went bald, or I don't know. It's hard to know what it would have been like if you hadn't been taking this stuff for 5 years.
Yeah.
Indeed.
Yeah.
No, I'm not. Don't worry, I'm no way doing that. Absolutely, I'd rather needle my head myself.
Well, I just think it has to be individualised, right?
Yeah.
What's important to you, what the balance of risk and reward,
Looks,
and all the rest of it.
Looks.
I don't know where I've got this rep from.
Hey, well, your mum told me it's from your dad.
That's exactly where I got it from. Right. Okay. So we're all about the pillars of lifestyle medicine here, right? And how can people take control of their own health? And so let's dial down into that for a little bit. What are some of the discussions you have with patients around managing their own testosterone levels for themselves without medication?
So I think the reason this is so important is it's potentially free. The risks of side effects and excessive levels, which you might get when you're administering a hormone to someone, just aren't there. So, even for the most diehard, keen to take testosterone treatment patient, these are still worth a try. I think the big threat. So your listeners already know what the 6 lifestyle medicine pillars are. Good.
They should do.
We hope so if they've watched the other episodes.
If not,
good.
can we block them from listening?
Yeah.
So they're all have a role to play. They're all really important. But probably the big 3, I would say, from a testosterone perspective, would be sleep, managing stress, and exercise. So it's not that diet doesn't have a role. I've already mentioned that people with very high alcohol intakes have impaired testosterone. It's not that that's not important, but these are, when we're talking about testosterone specifically, is so important. Sleep, because we've already mentioned that this circadian variation in the way it's secreted just means that if you stop someone from sleeping, you're going to shut down their testosterone production to some degree. I think those of us who, I used to work runs of 7 nights in A&E when I was a junior doctor, and a lot of those symptoms that you described, you ask any sort of male doctor after a week of nights and stress in A&E, and they're not going to have much testosterone floating around the system. So sleep's super important. Stress levels, again, whether it's pregnenolone, steal, high cortisol, or some evolutionary adaptation of trying to conserve energy for the right reasons, stress has a massively negative impact. So I guess the one we haven't spoke about in detail so far is exercise. And a question I'm commonly asked by patients is, what's the best type of exercise for improving testosterone levels? And I think the answer is it depends on the person. So it depends on what they already do and what potentially the causes for their low testosterone levels are. So I would say in someone like me, who isn't overweight, who I know is reasonably metabolically healthy, because I check these things on myself, and who does a reasonable amount of cardio type exercise, the biggest bang for my buck is going to be in strength training. So increasing lean muscle tissue. And it's a virtuous cycle, right? So you need testosterone to build muscle, but the body reacts to building muscle by secreting testosterone to support that muscle. So that, for someone like me, would be the most important thing. I think if you are metabolically unhealthy, overweight, pre-diabetic maybe, then you're probably, it's not that strength training isn't important, and there's a whole bunch of reasons why metabolically unhealthy people should be strength training as well, but they're probably going to see just as much, if not more, gain. And there have been some studies that were sort of, I don't know, misinterpreted by the headline of endurance training is actually better for testosterone than strength. It's not, but in a certain subgroup of the population, it probably is for them the optimal way of improving their testosterone levels. So I'm cheating really. The answer is both. It depends on the person and what other gains they're gonna think. If I could choose, I wouldn't be telling anyone to do one type of exercise. I never advise a patient to do that. But if we're going from zero to something, I might pick 20 minutes of more cardio-focused exercise to begin with if I think that's what they're going to respond to better. Does that make sense?
Yeah, absolutely. I mean, I know like typically what I've advised is strength training, and I think there's certainly research showing high intensity training also gives you a huge boost in testosterone, but high intensity training is not suitable for everyone, and it's it's often high risk depending on the form of high intensity training you're doing. So probably the best thing is to start something and do it safely and do it consistently, and then I think I'd go with you in a mix of zone 2 plus strength training is really important.
I mean, this is what we're all aiming for, right? Isn't it? It's our foundation of zone 2 through the week, which I'm sure you've talked about on previous podcasts. With the shorter duration, high intensity, and then the strength training on top of that. This is, it's hard to argue that this is the optimal strategy for almost everyone. I think the challenge comes is that when I'm in my day-to-day job, I'm not giving population level advice, I'm giving individual advice. So I might see someone who's very into strength training, who's overtraining, who's not allowing for recovery, and is seeing a hormonal impact of that. So they're doing the strength training, so they're doing the best form of training for the testosterone, but it's not working for them. So it's about, adapting and, sort of filling in the gaps. And I think the best type of exercise for anyone, it's like the best diet for anyone, is the one that you can stick to consistently, right? You knew I was going to say that.
I knew that,
Because it's like, you could go and sort of try and do your 3 rep max on a bench press later on this afternoon, but if you're not willing to do that week in, week out, then who cares that you did it once? It doesn't make any difference.
So generally, getting in the gym, getting moving, doing exercise is great for us all round, and potentially with testosterone as well. Is there too much of a good thing at any point?
Yes, absolutely. So I guess this would fall back into a stress category almost, if you like, a stress on the body. So we know that in female athletes that overtrain, one of the most reliable markers of that is that periods stop. That's the body adapting by prioritizing energy conservation over reproduction, and so you're going to see the same thing in other sex hormone levels. And so if overtraining is essentially placing an inappropriate stress on the body. It's not giving the body a chance to recover and adapt, and you're going to see downregulation of not just testosterone but various hormones in that setting. So recovery is key.
And that's why it's been redefined as REDS rather than the female athlete triad. So it's not just about females. This is one where we can steal back a bit. Overtraining can affect men's hormones as well. I think we see it a little bit more in endurance training. I've certainly noticed it a little bit in that kind of middle-aged male group that tend to do a lot of endurance work. There's a big group of cyclists here. You see them a lot, the middle-aged men in Lycra crew, where they potentially just do endurance training. They do a lot of it at a fairly high intensity, and they struggle to lose weight, actually. Sometimes you see they've got quite a lot of abdominal fat, and they might have issues that they disclose regarding drive, apathy, the mood things I talked about, and sex drive as well. And I often have a conversation with them about, actually, is your exercise appropriate at this point? is that something that we should be asking our patients about or talking to them about their training programs?
Absolutely. I think that goes beyond testosterone, right? That just goes into general good health advice, that if someone's training to the level where their well-being is being impaired, either whether it's in terms of their long-term health or in their mood, their energy right now, then that's something that we need to try and adjust and help them adapt to. I do think that there's also a problem. We talked about the ideal sort of exercise regimen, and too much of any one type of exercise is probably not helpful from a health perspective. Now, I recognize that people enjoy certain things. I play football a couple of times a week, spend an hour of my life getting kicked by other people, high chance that I'm going to injure my knee or break my leg or whatever, and I accept that that's not, from my sort of health span longevity perspective, I could get that cardio training in another way that was much safer from a long-term perspective. But you've got to accept that some people do what they love doing, but if that's harming them, then I think it's on us to try and explain that to them and help them find alternative ways to manage that. I think one of the reasons that illegal performance enhancing drugs work is they're recovery agents, right? So your middle-aged men in lycra that you see, if you flip it to the sort of the professional cyclist abusing steroids or EPO or whatever it is, it's allowing them to train to that level.
And even testosterone.
And recover and go again and go again and go again. Now that's clearly it's not great for them in the long term, but it's a useful window into how these hormones contribute to recovery and performance.
Even if it helps keep them motivated on the job, right?
Yeah.
Back to your football. You're talking about you getting kicked. You being the Liverpudlian, surely you're the one doing the kicking.
Very good. I'm not big or strong enough to do that, unfortunately. But yeah, no, I mean it is. I think it comes back to that. What's the best type of exercise? The one that someone's gonna stick to consistently. So it can be hard to tell a guy who's passionate about cycling, who's clearly overdoing, or passionate about lifting weights. Have you thought about, long-term health and maybe doing this or that? But it's a conversation.
And people are very, very attached to these things, but also it's their social connection, which is another pillar of lifestyle medicine. So I guess we've got to be, aware that when we make these suggestions,
stress management, comes in sleep, so comes into all those things. I think, you mentioned that they're actually, they can struggle to lose weight. They might have, central fat deposition. Part of that is adaptation, right? The body, if you don't sort of constantly surprise it with new movements, new form of exercise, it is very easy to sort of get stuck in a rut by doing the same thing over and over
and
again.
Also, as you said, it's a stressor, right? So you've got potentially high cortisol from the training, which is going to increase adipose storage, fat storage, potentially around the abdomen.
Yeah.
So they might be shooting themselves in the foot a little bit with it.
I think if we took someone who was doing intensive training and measured a bunch of their parameters, their blood pressure, their cortisol levels, their ferritin levels, their CK, or a bunch of markers, and then you showed them to a doctor without explaining the context, they'd say, this person's in trouble. The whole point of exercise is that it's a temporary stressor, and then the body adapts to those things. But if you don't give it a chance to adapt after it's done them, then you don't get the benefit of the stressor. So it has to be a temporary thing.
Well, is that? I know you always gnaws out on interleukins, but I said IL-6 goes up in a previous podcast. But actually, IL-6 is pro-inflammatory, but then it eventually comes down because you get this spike in adaptation, and then but if you're always spiking IL-6, you're constantly inflamed. Okay, so that's exercise. So sleep. You mentioned sleep. What's some advice that you give to your patients regarding sleep?
So a lot of what we talk about, and this you could do a whole podcast on sleep, right? I mean, Matt Walker has a whole podcast series on sleep.
Amazing.
Another Liverpudlian, actually.
Yeah, and you look, he's Liverpudlian. He looks a little bit like me. So if we combined us, we'd get Matt Walker. Brilliant.
So again, if we focus on lifestyle, it's around sleep, hygiene measures, and routine. So people tend to respond better if they go to bed and get up at similar times of day, even at the weekend, which some people don't want to hear. This idea that you can repay a sleep debt at the weekend isn't, maybe up to an hour or two, but beyond that, it's not going to happen. So consistency is one thing, so getting the body into a habit. You can do the Huberman stuff, your morning sunlight, you're seeing the sunset, seems to have an impact. He talks about circadian dead zones in the middle of the day where getting sunlight isn't bad for you but doesn't seem to benefit your sleep. So it seems to be morning and evening that make a difference. So you could combine that with your exercise. Screens is one I'm always getting asked about, and I think it's two things with screens. One is the light, so shining blue light into your eyes just before you go to bed clearly isn't a sensible thing to do if you want to get to sleep, but it seems to be more than just the light. It seems to be the stimulating activity. So it's the checking emails, it's the going on Twitter, or X, or whatever he's calling it these days. It's not just the light from the screen, it's the fact that phones are designed, and apps are designed to be addictive and stimulating and all the rest of it. So that's definitely a double-edged sword. So put your devices away is a hard one to do, but a worthwhile one to try.
Don't check your TikTok followers just before bed.
Yeah, exactly.
You're talking to yourself there, aren't you?
Having a dark room or wearing an eye mask, having a quiet, cool environment seems to be slightly colder is better than slightly warmer, which is useful to know in Singapore. And the other thing a lot of patients want to talk to me about is supplements for sleep. Although I would really try and do all those lifestyle measures first, and sleep medications are very unhelpful. It's chemically induced sleep that's not very restorative, and most of them are addictive as well. There are some natural things that you can take which are safe and relatively inexpensive, which might be worth a try. Probably the ones I recommend the most would be a form of magnesium that is able to cross the blood-brain barrier or is readily absorbed, at least, like magnesium 3 and 8. Is the one I use at bedtime, or magnesium glycinate in the day. L3 and 8, another commonly available sleep supplement. Not one if you get vivid dreams or you're a sleepwalker, but other than that, can be worth a try. What else have we got? Ashwagandha, lemon balm extract. Are there any others I recommend?
So people often talk about melatonin. From what I've heard, in a low dose is pretty more effective, and potentially it's great for jet lag.
Yeah.
And it sort of gets you to the start block of sleep, but doesn't actually help with your sleep. Is that something that you go along with? Do you ever prescribe it or suggest it?
So I mean, yeah, we do prescribe it, but you don't need a prescription to get it in Singapore. So I think the way to think about melatonin is it doesn't make you fall asleep in its natural form when it's released. It prepares the body for sleep. So you don't take it just before you want to get to sleep. You need to take it a little while before. My worry about melatonin is with sustained use. So are we down regulating natural melatonin production? The same way that you give someone testosterone for long enough, you might over time down-regulate their natural production. The same thing happens with melatonin. So I use it for things like jet lag. I might use it to break a cycle of sleeplessness, and it can be really helpful if people respond to it.
Yeah.
But it's not something that I would take indefinitely, like those other supplements I mentioned, which if someone wants to take magnesium, they can take it forever.
Yeah. Brilliant. And a lot of people are deficient, I think.
And your body's very good at dealing with the excess. So I mean, I don't want people taking stuff unnecessarily and wasting their money, but it's hard to take too much magnesium. If you're sticking to standard doses, your kidneys will just excrete any excess. I wouldn't try all those supplements I mentioned, by the way. I wouldn't try them all at once. You need to work out what does work and doesn't work for you. So I would try them one at a time.
Oh, it's the same in exercise prescription as well. Yeah, just do one at a time. You know what's working. We talked last week. We had Dr. Yu on here, and for anyone that hasn't heard that, it's fantastic. We talked about sleep quality, and particularly nasal breathing. And by training nasal breathing during the day, you might improve your nasal breathing at night, which may have an impact on sleep apnea. So I think, do you see that in patients with sleep apnea, they might suffer? Is there any correlation with testosterone issues?
Yes. Yeah. Don't even need to elaborate too much on that one, 100%. I mean, it's tied into a lot of people with sleep apnea have poor metabolic health as well.
Correct, yeah.
Not all of them.
Yeah.
But yeah, absolutely. And anything that you do that disrupts sleep, whether it's from sleep apnea to going and kicking them out of bed or setting an alarm or making them work, shift work, anything that disrupts sleep will have this negative impact on testosterone production.
And again, back to that cortisol effect. So if you can't breathe at night, that's a huge stressor to the body. Doctor, you mentioned blood pressure going up. Your whole stress hormone cascade. And
Absolutely,
then,
big cardiovascular risk factor.
Factors,
So it working out if someone has sleep apnea. I guess the sleep advice I was giving in terms of lifestyle and supplements is more generic when we're assuming there isn't a greater underlying problem. For someone who has the symptoms of sleep apnea, which I'm not going to go over because I'm sure they were covered in your previous podcast, then that would need to be addressed. Interestingly, with the sort of the advent of the newer weight loss medications in the US, a number of CPAP manufacturers are apparently struggling somewhat because people are losing so much weight that they don't need to use their CPAP machines anymore. So an interesting side effect of the weight loss medicine craze that's going on there.
I don't want to say good, that's nasty, but no, good.
Interesting.
Yeah, interesting.
The way these things pan out, right?
I mean, I wish people could, do that naturally, and hopefully with the exercise advice and the stress management and some of the breathing retraining, they can do it naturally.
So, if I wanted to boost my testosterone sort of more naturally, what supplements would you recommend?
So, recommends may be a strong word, but which ones would I not dissuade you from taking? There's loads out there. I think you've got to be careful about what's in them, because a lot of them are mixed ingredients. They're often branded in a similar way to you see pre-workout, and there'll be caffeine, there'll be all kinds in there. So, what are we actually interested in? Probably the two most commonly seen in my practice would be Tongkat Ali, particularly in this part of the world because it's a Southeast Asian traditional treatment for libido and fertility and erections and that kind of thing. And the Nigerian one, I always have to write it down, Fidogia agrestis. So you don't see that as much. But these things are often mixed up in a pill or a powder or whatever and branded as Testo Boost or Testo Jack or that kind of thing. There is some evidence for both of them. Tongkat Ali seems to improve free and total testosterone levels, may have some role in regulating stress hormone levels as well. Haven't seen people running into big problems in terms of effects with it. The absolute numbers that you see in terms of increase in testosterone in studies aren't that impressive, but as we've already alluded to, you see people responding in some cases quite well to fairly minimal changes in their absolute numbers. So it might be worth a try. I think you're unlikely to tip yourself into excess with a supplement. I did get asked recently by a guy who was already taking 3 testosterone boosting supplements whether he should add a 4th and didn't know what his testosterone level was. So sort of maybe just know what your level is and then you could make that decision. I'm not sure that stacking them on top of each other is really going to have a huge impact.
One of the blokes played golf with. I'd never heard of Tongkat Ali, but we were just like discussing health, and I was like telling him about my lower testosterone. He's like, "Mate, you need to take some Tongkat Ali. Been trying for a baby, been absolutely smashing it. Feel really good." Yeah. So.
And did you take him up on his advice?
I did take him up on it. I did take some. I don't take it that regularly, but sometimes I do, and I do feel a bit of a boost. Yeah.
Yeah, but that's because it comes with horny goat weed.
Well, I don't know if mine does. Does it? Is it the one which I sent? Did I send you the link?
Yep.
Yeah. Okay.
It does.
Well,
I left it out on the side. I'm sure the helper found that amusing.
I enjoyed it.
Good.
And did you try it?
Yeah, I did. I took it for a few weeks.
Did it have any effect on you, old boy?
Really hard to say, to be honest. I actually stopped it because I didn't feel like a huge effect on it. And I was wondering, can taking these supplements, can it affect things like skin health, for example? So if your testosterone is going up, can that affect your skin health?
Yeah, so testosterone has an impact on your skin. Whether the supplements could push your testosterone to a level where they did, I mean, you would have to see the individual response. But one of the symptoms of excess androgen is acne.
So that's what I thought. So I took it,
Man, you've got so much testosterone.
Well, it must be. Well, that's it. I don't want to go on about it, but yeah, that's why I thought there
Right.
might be some.
Now
some
it
of
may
that.
be transient. You may have said, well, if you just kept going with the acne would settle down. It's just an adaptation. But absolutely, that could have been a genuine side effect.
And actually, while we're on that, in terms of side effects of supplementation, what are the big risks in terms of supplementing testosterone?
So, the symptoms of testosterone excess, we've already mentioned acne. There are other concerns. So we know that testosterone causes hair growth on the bits of the body we don't particularly want to grow more hair, and hair loss on the scalp. So if that's an important thing to you, you have to recognize that male pattern baldness happens because of testosterone in the scalp, and so that's a potential side effect. It can affect sperm count. And so this is a really important conversation to have with anyone who still has plans to start or continue a family down the line, have children. It's a massive consideration. There are the behavioral sort of side effects, so some people might find that the risk-taking, aggressiveness, impulsivity actually tips into a negative rather than a positive. And then there's the effects on other body systems. So the prostate. There's long been a debate, does testosterone therapy cause prostate cancer? It appears the answer is no, but you definitely don't want to be giving it to a guy who has prostate cancer and doesn't know about it. So prostate screening, if age appropriate, might be something that's worthwhile before doing this. Fairly easy to do. For a guy who's got a very enlarged prostate that's giving him symptoms, could make that worse. So there are these considerations. There's the effect on the cardiovascular system. So does it increase your risk of heart attack or stroke, increase your cholesterol, possibly transiently. So again, someone with critical disease may not be the best decision for them. But because of its beneficial effects on metabolism, I think for most guys, it's going to benefit them in that regard in the long term rather than have a negative impact.
As it supports growth in general, does it, aside from prostate cancer, are there any risks for overall cancer risk? Or if you already have cancer, can it worsen things?
Not that I'm aware of. Do you mean that it would it increase tumor proliferation?
Yes.
and that kind of? Not that I'm aware of. So the issue with certain prostate cancers and on the estrogen side, breast cancer in women, is that those tumor cells have hormone receptors that are then stimulated by the hormone.
Yeah.
I can't give you a plausible explanation for why someone with pancreatic cancer would have that stimulated by taking testosterone.
So it has to be a testosterone sensitive.
Yeah. So in men, we're really looking at prostate being the worry. In women, ovarian and breast cancers, I guess, would be a concern. I mean, listen, if someone has one of these cancers, that's the conversation I'm having with them. We might leave their hormone levels for another time. You got to sort out the primary issue and then worry about what you're going to do next.
So I guess on that note, we spoke last time when we spoke about estrogen, we spoke about men. So to be fair, we should talk about women when we're talking about testosterone. Yeah. Is testosterone something women need to be considering?
Yes, it is. Clearly, they have far lower levels than men, but it doesn't mean that it's not necessary for healthy functioning in all the regards that we've already spoken about: sexual function, psychological function, performance, and training, and that side of things. I think the women that you're most likely to see this in, the starkest example of testosterone deficiency in a woman is in women who have gone through prematurely induced menopause. So women that have had their ovaries removed for some other medical reason. When you check their hormone levels, their testosterone just is absolutely tanked. Obviously, they've got low estrogen and other things going on. It's like the adrenals can't make up for that sort of deficit, and those women can become very symptomatic from the low testosterone. Testosterone also dips after the menopause quite considerably. So in that context, in the menopause HRT context, testosterone is most often talked about in terms of sexual function. So women that report loss of libido, loss of pleasure from sex, pain, discomfort, that kind of thing, sometimes testosterone is piggybacked onto HRT to benefit those symptoms. And it definitely does make a difference. It's rare for us to use testosterone on its own in women. And it's certainly true that for most women, estrogen will be enough. In most cases, more standard hormone replacement will be enough to address the sexual symptoms as well. But if it's not, testosterone at a very low dose. So I talked about these sachets of gel, using them once every day or once every other day in a man. You'd be making one sachet of gel last 10 days in a woman. So one of the challenges, and very topical the day after International Women's Day, is that all testosterone formulations are manufactured with men in mind. And so if we're giving them to women, we're sort of cheating a male preparation and trying to work out a way of giving it very infrequently or at a low dose, which is annoying, but that's where we're at the moment.
That's very informative. Thank you. It's been a very informative podcast. Thank you very much.
It's been a pleasure.
Let's see if we can summarize things a little bit for people listening. And if you could leave our listeners with 3 key take-home messages, what would they be?
This is one that you gave me in advance, so I'm cheating a bit here. I had a chance to think about it. I would say the first thing is you've got to know whether there's a problem. So knowing the symptoms, hopefully we've played a small role in helping people with that. If you don't know what the symptoms are, how are you ever going to know that it's an issue? So awareness is one thing. My number 2 would be remembering the importance of lifestyle. So everyone gets bogged down in testosterone replacement and treatment, and actually that's sort of the tip of the iceberg, and some people will need that, but the vast majority of us can improve our levels through lifestyle measures that are going to benefit other aspects of our health as well. So we're going to get the double whammy of a testosterone boost and better metabolic, cardiovascular health and all the rest of it. So I think that's really important. And the final thing is, I would say, and you might say, well, he would say this, wouldn't it? But I would say get good advice if you're going to, particularly if you're going to go down the treatment route. Don't do things without knowing what your levels are. It's super easy to get your levels checked. So don't do it by yourself. I don't think this is as much of an issue in Singapore because it's harder to come by. In the US, there's a testosterone clinic on every high street corner, and they're giving the stuff out. Yeah. So I don't think that's as much of an issue here, but if you're thinking about it, bounce your ideas off someone. I hope the impression you've got from me in this podcast is there's no hard or fast rules. It's not you can't have testosterone, you can. It's very individualized, but it's good to have a conversation with someone who's experienced in using it before just jumping in at the deep end.
And also getting a baseline and then being able to retest and seeing does that correlate with how I'm feeling as well. Brilliant.
Fantastic. All right, so now we're out through the bulk of today. We're going to go through to our 2 favourite segments. We'll start with our pet peeves, and that's where we discuss our pet peeve of our profession. So if you want to give us your pet peeve of your profession.
So I thought of one that was about, it was almost in defence of my profession, my pet peeve, rather than about something that doctors do. So am I allowed 2 pet peeves?
Have 2
pet
pet peeves, because then we can split.
Can we discuss that? Is he allowed 2 pet peeves? Does he deserve it?
We'll let him have 2, and then if one's rubbish, we can cut one out.
Yeah, go on then.
I think one's in defence of doctors and one's in criticism of doctors. So I think we're here to talk about testosterone. So I think the thing that maybe the medical profession doesn't do well is it's too rigid in its approach to how this is managed. So people have their levels checked and are told, you're not deficient, go away, there's nothing wrong. And hopefully the last however long we've spoken about it tells you just how nuanced and complicated this is, and that it's not just as straightforward as too low, too high. So I do think that's something that we need to get much better at, is understanding the individualization, personalization of managing testosterone. But I think on the flip side of that, what I increasingly see on social media is this oversimplification of the process. Do this one thing and it'll fix everything. And this idea that doctors don't know or don't care about the underlying causes for stuff. There are good doctors and bad doctors in the same way that there's good physios and good podiatrists and terrible ones, right? But I think the idea that someone comes to see me and I just give you a drug and I don't really care what the underlying cause is, that's not true. But that seems to have become a trope. Here's the thing your doctor doesn't understand, or here's the thing that your doctor won't tell you. And I think we're all as guilty of that as anyone else at times. But I think there's this great trend for doctor bashing on social media sometimes to sensationalize.
That's
and we're not all terrible people.
Oh, 100%.
Some of us are okay.
I think it's come from an awful system rather than awful doctors. So I think if ever it has come from anything, it's come from, look, you've worked in the NHS, you get 3.5 minutes with a patient, you have to do what you have to do. And then perhaps in some other places in the world it's similar. So I always think if there is ever a fault, it's with the systems that people have to work in.
Yeah, and it fits with a sort of a conspiracy view of the world that, the medical profession is in league with Big Pharma to stop you from
getting better.
Yeah, which, there are some terrible aspects to Big Pharma, of course. But, if I think that someone needs testosterone treatment, it's nothing to do with the pharmaceutical. I don't even know who makes Nabida. So it's not a scam. It's not that I'm, ignoring the lifestyle factors or anything like that. It's trying to find the best solution for the individual.
I think it's been very clear that that's exactly your approach to medicine today.
That's good.
So thanks for sharing that.
That's good.
Yeah. And our final segment is our Magic Wand segment.
Not like that.
And this is where we...
That's terrible, lads. Terrible.
But we're never going to stop it.
No, it's going to be, in a few years, 300 episodes old. Okay, and this is where we decipher our one wish for our patient group. Okay,
So, yeah, I had a good think about this one. And this isn't true for all. Some of my patients do manage to do this. So I guess I don't need the magic wand for everyone. But we talked so much about lifestyle in terms of sleep and exercise and all that good stuff. And what I'd really like people to see is the value of the process as well as the end result. Because some of this management of hormones is quite long-winded. It's not like, you come to see me with an ear infection and I give you some medicine and it gets better and the whole episode is over in 5 days. There's a lot of trial and error here, and part of the joy is in the process of making tiny little incremental gains. And I think some of the people I see are so worried about the end result that they miss all the great stuff that they're able to do in the getting there. It's just not binary. So I don't know if that's a slightly weird one, but if I could make people see the value of the process as well as the result, then I think people would be happier with their management.
It's not weird at all, is it? And the same, like James Clear said, everyone's got a goal, but it's the processes you put in place that are the most important thing.
Yeah, and I think the people who often do well are the ones that can take pleasure and motivation from the process and be slightly less results driven. I think those people wind up a bit happier than the ones that if you're only focused on the result and you don't achieve the result, then you're setting yourself up for disappointments. And so I think if we can help people see that lifestyle medicine is a lifelong endeavor rather than just a course of treatment and here you go, it's all over, then that would be my wish.
Love that.
Love it. Very good.
Thank you so much for listening and joining us in our collaborative journey to health and performance.
Please do smash the like button. Send your comments if you have anything you specifically want to see from us or any guests that you want us to have on. And in the next episode, we'll be talking about the role of muscle in sexual health. We're looking forward to that one, and it definitely links into what we've been discussing today.
Thanks again to Dr. Neil Forrest. And for all of you listening, value the process and take good care of yourselves.
Thank you.